Now we're going to have a panel. If I can invite our panellists up. We have Georgia Shepherd from the Women's. Georgia, if you come up and just take a seat. Stuart McCulloch, who's the CEO of VHIA, Victorian Health something, he'll tell us. And Elizabeth McLinden from the University of Melbourne. Okay, so now I'm sorry the people over there might not be able to see us all, but hopefully you can hear us. You're welcome to move if you want to as well. There are some places down here. So we are going to focus in the panel today on supporting staff first. So we've already heard a little bit today about the need to support all of you and support staff working in this area. So can we just start with initial thoughts from each of you, what's happening where you are? Let's just start there and then we'll go from there. Georgia, we'll start with you. You've got your lapel, yes?
Yeah, great. Good morning, everyone. So what's happening? We are almost 3 years into our family violence program at the Royal Women's Hospital. And we were fortunate enough to receive some funding from the department to take our expertise, our learnings, our failures and our successes and turn those into a resource to support other hospitals as they embark upon their journey. So that's been a really major part of focus from the Women's for 2018. And we've been really privileged to work with a number of great health services across Victoria and support them in their work as well. That's where we're up to.
Okay, fantastic. And Stuart, sorry, I couldn't get the whole acronym.
That's all right. It's difficult. So it's the Victorian something.
Yes, that's what I said.
The Victorian Hospitals Industrial Association. So our little part of this is really just in the industrial relations sphere and the introduction of family violence provisions, including family violence leave into enterprise agreements. So really in terms of what's happening for us is those have been introduced since 2016, and the process really for us is to think about what steps can we take as an industrial organisation to support the effective implementation of those provisions, having regard for the great resources developed by the Royal Women's and our member organisations. We've done some podcast work, but it really is about how do we generate information that supports that implementation process.
And what are, as they currently stand, what are the provisions for family violence for workers?
So it's interesting. The clause is called family violence leave. Most of you will be familiar with that. It's been introduced through our agreements as they've expired and been renewed from 2016, starting with the Nurses and Midwives Agreement. And so really it falls into two distinct categories. There's a leave provision of up to 20 days, which is paid leave. But the second component is really about how to manage the circumstance within the workplace and the challenges associated with that. So it's unusual for us to have a leave provision that does more than have leave. But that's really, all those provisions sit together under the one clause. They're not divided off into different areas of the agreement, with the view that people can look to one place to find out A, what their rights and entitlements are, that employers can know what their obligations are, and what their obligations are to support employees who are experiencing family violence.
Fantastic. So we'll come back to those provisions as well. But Elizabeth, so you're with UniMelb and the Women's. So what's your point of view on this?
Where do I sit?
Yeah.
Well, I've worked at the Women's for 10 years and was working as a social worker with women who were dealing with the health consequences of violence and accessing antenatal care. And then a couple of years ago, as we were increasing what we were doing at the Women's in responding to patients who'd experienced violence, I sat down with a group of people, including Kelsey Hegarty, who's one of my PhD supervisors, to talk about, well, what happens when health professionals themselves, the majority of whom are women, have experienced violence. What do we know about how frequently they experience violence? And perhaps more importantly, what are the impacts if they've experienced violence when they go to work and identify and intervene with patients who have experienced violence? So I'm at the end of a long PhD that's seen the birth of 2 physical babies and hopefully a paper-versed version of a baby in a few months' time. I'm wanting to talk a little bit about what we now know about health professionals who've experienced violence, and I've been really lucky to be able to turn some of the findings of that into working with the women's around how do we support other hospitals to support their health professionals in this space.
Great. So, I mean, one of the things that I notice in attending various forums, and we will have a panel on this later, but there is, if we talk about employee well-being, it's often focused on self-care, which is fantastic. We need to talk about self-care, and particularly if you work in the caring professions. But sometimes it's at the neglect of the responsibility of the employer. So today, in this particular panel, we're really more focused on that. So as you said, we know, and we've heard many times, we know that employees are subject to family violence. We know that, especially in a female-dominated workforce. So Georgia, how do we break down the idea of sort of, if I can put it this way, the professional and personal worlds kind of colliding?
They do, very much so. I think one of the important things, just going back to Stuart's comment on the enterprise agreement clause, is to implement in a way that does no harm. And it is one of the most complex clauses that I've ever had to interpret and implement in my entire HR career. It's been really complex because it's not just about working out a payroll process to process some family violence leave. It's not just about, doing a bit of safety planning. It's about entrenching a really deep and compassionate understanding of what our staff are experiencing, so we do no harm.
So it's not just physical harm, if I can put it that way, as in you're not just looking at is this person at physical risk, but career harm, emotional harm.
It's more likely to be some psychological trauma that we might inflict upon our staff as we ask them to care for our patients without actually doing something to think about them as well. The other thing I was really mindful of is when we were doing the work to implement that clause is, to me, that manager education was really front and foremost, in that I was very mindful, it used to keep me awake at night, that our managers, while incredibly compassionate and well-meaning people, might dispense with some incredibly unsafe advice in the attempt to help the staff. So I think an education piece was so fundamental to make sure that we offer family violence leave, a safety planning, workplace flexibility in a way that keeps our staff very, very safe. I think the other thing is that it's not just about the clause. There's a much wider wraparound piece that is really necessary to destigmatise family violence and to get a conversation going. And that's where that leadership and the organisational communication piece was so important, to get a message out there, to acknowledge it, that it happens. It's not just the behind closed doors, it comes into the workplace as well, because people bring their backgrounds into the workplace, of course they do. And to have messages, events, promotion pieces to acknowledge the existence of family violence in our staff. And you know what, for some people, even just having it spoken out loud was enough to hold them for that. Not for everyone, we need to do more depending on what individuals need, but I think that goes a very, very long way in supporting our staff in order for them to give the best attention needed to our patients.
Well, it's interesting too, it strikes me, it's a similar moment in time in a way to discussions around mental health, where we're encouraging people in general and workers to acknowledge mental health issues, but we're also aware that there's still stigma around mental health issues, and people are concerned about the effect on their career and how they'll be perceived. Can we get around that? Are we trying to get around that?
Gee, that's a really interesting question.
Well, thank you.
One of the interesting things about coming up with family violence leave models is what is the best model in terms of confidentiality, in terms of stigma. It was really interesting for me to look at the social media comments that were being posted at the time that the model was being developed. And the instinct for a lot of people was to make a comment to say that, look, we use sick leave for this purpose, even though it's not designed for that purpose, that's what we utilise, and that way we don't need to identify as such. And it's been interesting to see that we've got a shift to a specific provision that does have confidentiality and measures to reduce stigma, but also invites people to engage with the subject more directly. And I think one of the interesting things for us is at some point to get a sense of how the clause is working. Is it doing the job that we want it to do? Are there barriers to access? and that's work that's yet to occur. It's 56 weeks until we're due to start renegotiating a new agreement for nurses and midwives, and at some point it would be good to evaluate how that clause is operating to see whether it's addressing stigma issues appropriately.
Because, I mean, presumably in an ideal world, if you're experiencing family violence or some other form of harm, you'd walk into HR and say, I need to use this provision and you can help me, and you wouldn't be concerned, but we don't live in that world yet, do we?
It's important to remember that the point's been made that there are 88 health services and they come in all shapes and sizes. So of those health services, half of them don't have HR. Half of them don't have that resource, and HR is a responsibility that falls to someone who wears multiple hats. So one of the challenges for us is about developing things that support implementation, not just in large health services, although the work they do is very important, but at those smaller health services as well, where there isn't that sort of dedicated resource.
And Elizabeth, in terms of the potential for harm, because again, I think, you know, the road to, what is it, good intentions paved, whatever it is. What are some of the things we should look out for in terms of the potential for harm? Like, there are managers in the room who have good intentions but may not know exactly what to do. What are we looking out for not to do?
Well, I think as Kelsey and Rachel talked about in the earlier session, hearing from a woman about what her experience is and her assessment around her safety and the impacts that she's identifying that violence or the implications of violence is having on her work and what she needs is really important. So having, just like we do with any woman, patient or staff, a woman being in control of her story, her experience, and being able to tell us what she needs is really fundamentally important. But I just want to mention something else, because I think, you know, you said before that we know that health professionals themselves are victim survivors, and you're absolutely right, we do. And in fact, we know the first part of our research showed that just under half of health professionals, 45% of the 500 odd women that we surveyed, had experienced either violence as an adult or violence as a child, or both within the family context. But the second part of the research that we did was about what work people who are survivors of family violence are doing with their patients. And are survivors of family violence who are health professionals, are they doing more or less of the evidence-based work we want people to do with patients? So by that I mean, are they asking more patients questions about family violence and therefore identifying more patients? And once a patient who's experiencing family violence has been identified, what are the interventions, things like risk assessments and safety planning and referrals, what are the interventions that those survivor health professionals are doing? And our analysis showed that survivor health professionals are doing more of the work that we see as best practice with patients who have experienced violence. And so in fact, they're a real asset to the healthcare and other organisations in which they work.
Just to clarify, so people who have either directly experienced or been in homes where they've experienced family violence are more likely to implement best practice with patients experiencing it, as opposed to, I think, sometimes a knee-jerk reaction that they will back away from it.
That's right. I think we do have a misconception. You know, I've seen it in practice for years, that people who have experienced family violence may have additional barriers to being able to go there with their patients. And, you know, we've been able to show that in fact these people are doing a really great amount of work. First and foremost, people who have experienced family violence and who are healthcare professionals are going to more family violence training than people who haven't experienced family violence. So from the get-go, they're identifying this as an important issue. So I put that out there because I think that's a really important thing for us to be thinking about. We now know many of our health professionals, about half, have experienced family violence. We know that they're keen...
Yeah, sorry, just on that note before I forget, are they less at risk of what I would sort of broadly call that paternalistic attitude toward victim survivors of, well, you should leave, or you should do this, or you should do that? Are people who experienced it
attitudes? So part of part of the survey that we did look at attitudes, and so certainly people who have experienced family violence had more sensitive attitudes about survivors. That was more gender equitable. That is certainly part of it. Yeah. So I think when we think about workplaces and going to the point about leave, we did ask the hundreds of health professionals about what they thought of domestic violence leave, either paid leave or otherwise, and people were pretty ambivalent about domestic violence leave as an issue. About half of people thought it was important, and another half of people thought, I don't know that I would use it if it meant identifying that I was a survivor myself. But what people were not unequivocal about, they were unequivocal, what people were really sure about was that they wanted all managers within their workplace to be trained in how to respond to a disclosure of family violence. They thought that HR needed to be trained, and they thought that the employee assistance program staff that were an option for counselling, either short or a bit longer term, that they should have specialist training in family violence. So we know that that's what people want, and it makes real sense, and I guess that's what we're trying to do now across the state, certainly in terms of manager and HR training.
Can I just make another point about the training? Most of you would understand there's Module 1 and Module 2 training. In my view, it's not enough to offer those and think, job done, we've trained our staff. Because we've had actual real life experiences of staff who have been trained in Module 1 and 2 and have been really experts at identifying family violence in their staff and felt really confident to treat their staff, but neglected to recognise it in themselves, or if they knew there was something quite wrong, had a different way of rationalising what was going on, didn't call it for what it was. So it's not enough just to go Module 1 and 2, job done. There's a real need to train for recognition within your staff, because it's not a guaranteed fact that your staff, just because they've done the patient-related training, that they will know the signs within themselves, because I'm telling you that doesn't happen. It's really important that you have a manager watching out for them to see if something's not quite right, or some signs, and train to very right question, right time, but very sensitively ask that question, because we know that for a fact within our organisation.
Well, and I mean, humans in general are incredibly complex, but humans who are traumatised are even more complex.
Yeah, they won't join the dots for themselves.
No.
They'll do it for the patients, but not for themselves.
Yeah, absolutely. And I mean, it strikes me as well when you're talking about any HR reform, industrial reform, whatever it is, implementing family violence leave, there's not an industrial reform that hasn't had resistance, or where some part of the workforce would have resisted it. So it's sort of not uncommon in a way, is it? I mean, it's
interesting. I would actually
or is there more resistance than usual?
No.
Less?
I would say that in this instance, one of the things that we struggle with is to make major change and implement in industrial relations. And in this instance, my sense is that there is a lot of support, a lot of goodwill. And there was a comment that Sue made before about putting a piece of artwork in the lobby. And you can actually tell where it ranks, what the priorities of a health service are when you walk into reception. And I can say that when I walk into Benalla Hospital, the first thing I see there is that family violence is a priority. And when you go into Warracknabeal, there's a sign out the front of that town that says that dealing with family violence is a priority. And it's true for Maryborough, it's true for lots of different places. So there's a lot of support, and that's translated into the industrial area, but it's really about familiarity. It's about confidence with the term. It's about understanding how to deal with the confidentiality.
Because all of these things add up, don't they? They're not just one thing, but seeing that poster, seeing that, hearing the reform, hearing the news story. I'll get questions from the floor, I think. I'm allowed to do that in a moment. Am I allowed to do that? Yes? But Stuart, can you just explain in terms of, so you have the provision for the leave. So let's say I come to HR and I say I need to use the family violence leave. What's the other part that you mentioned at the beginning that comes with that that's different to sick leave?
So a couple of things to say. Just the first thing about the leave provision is that there's more than one pathway. It's not solely to HR. It can be to family violence contacts or to the supervisor. But in terms of the other...
Can I just interrupt for 1 second? Someone's got a microphone on near some rustling papers. Whoever that is, if you could, can you turn that down for us? Thank you. Sorry.
I thought there was going to be a spotlight. But in terms of the other components, it's really about thinking about what's necessary to support the employee in terms of employee assistance programs, but also about the workplace. So hospitals are really tricky things in terms of workplaces in that anybody can turn up. And that's a really unique challenge in terms of if somebody's experiencing that, what do you do? And it is, Georgia made reference before to a safety plan, and that is turning your mind, do you need to change contact details? Do you need to change location or times? What kind of protocols do you introduce to make it a safe workplace? Because everybody has an obligation to ensure the workplace is safe, but there are some really unique challenges for health services in that respect.
And what happens if someone's partner rings up and says, "Oh, is Nellie at work? And do you know when she'll be in?" And she was meant to, you could inadvertently, if you're not trained, give away information that causes someone to be unsafe. Yeah. Okay, we've got 6 minutes exactly for questions. So if you've got a question, don't be shy. Throw your hand up. You're going to have to put your hand up. Yep. Okay, over here. Go for it. I'm sorry. If you could just use that microphone, that'd be fantastic.
Hi there, Jerry from Peter Mac. I'm interested in the issue of how other health services deal with perpetrators working in the workplace, and can they access the family violence leave? Because this is an issue that's come up for us.
No, Jerry, they can't. No,
Yeah.
is in my opinion, the family violence leave is there for victim survivors of family violence, and it's my understanding of the purpose of the clause and even the technical reading of the clause. No, they're not entitled to family violence leave. That's not to say that organisations can't support perpetrators with absences to attend to whatever it is they need to attend to through taking their annual leave, ADO, unpaid leave, whatever, special paid leave. But I also think of the message that might send to victim survivors by allowing access to that. I don't think it's the purpose, but it doesn't mean that we cannot support them in other ways.
So is that, Stuart, because I knew this question was going to come up, do you think that understanding is across the sector? I mean, obviously at the women's, the family violence provisions are used for victim survivors. Is it used elsewhere for perpetrators, or is it very clear the intentions for victim survivors?
Look, it's really interesting to hear that question. That's the second time I've been asked that question. And the way it was put to me was really interesting. It was put that, well, you may not know that the perpetrator is actually guilty. And that's a really troublesome kind of approach. I can honestly say that when the parties sat around the table to develop that clause, it was for victims. Georgia is absolutely correct. That is the purpose of the provision. And there are a multitude of other ways to deal with other issues, but not through that provision.
I think we also have to be mindful, though, that sometimes perpetrators have a past experience where they have been a victim survivor of family violence. So I guess it might depend on the purpose of the leave, whether it's to attend court as a perpetrator or to seek counselling as a victim survivor. So there can be that additional complexity in it as well.
But the intention's very clear that the provision is to help mostly women, not only, but mostly women who are victim survivors.
By default,
survivors.
they will be mostly
Yes,
women who
mostly
access the
women.
provision as that clause, right? Yep.
Yeah. Other questions? Yeah. Sorry, we'll just wait for a microphone. Do we have to use the microphones? We do. Okay. Just stand here. Okay.
My name's Kathy. I'm a family violence survivor advocate with Safe Steps. And I guess a question I'd be interested in asking around all the industrial relations side of the leave is that, for example, if you're someone who is going through a point of crisis in the relationship, that seems fairly clear cut. But what if you're someone who's a number of years out of the relationship, but you're on the path of your healing and recovery? The impact of the trauma, the depression, the PTSD, the physical injuries that are still flaring up, and you're, I guess, under most leave provisions, you'd be thinking, oh, I'll take my sick leave. But really, the root cause of that has been a result of the violent crimes and offences committed against you. I would like to think that people could feel that they could access their family violence leave, even though it's fitting under a sick leave category.
So, Kathy, I guess your if I can paraphrase your question is, do you have to be in a current situation of family violence to access the family violence leave, or can it be from any effects from family violence? Who wants to take that one?
Yeah, happy to.
Yeah, Stuart, go for it.
That. You've touched on a really interesting point. So in industrial relations, we like things to be unambiguous and binary, either in or out.
This is a great area for that, isn't it?
Sorry, I didn't identify myself as a lawyer also. So this is a different area, and I would say that we're on a bit of a learning process about how to think about the fact that some of the issues may be completely disconnected in terms of time. And that's a new challenge for us, and that's a new learning for us. I would say in terms of health services, this is an evolution. It's not a case of flicking the switch and getting it right. There'll be instances where people have to turn their mind and think it through as such. But the clause itself doesn't say that, doesn't require proximity in terms of the event and the outcome. I mean, for example, court appearances are expressly referred to in the provision. And we know that court appearances can have a complete disconnection from the timing of the event that triggered that court appearance. So, and the same is true in terms of any trauma of the kind that you described. But we will need to continue to be curious and continue to develop and learn in order to understand that better. And that's a process that's not finished.
I think one of the things is we know there's not a linear relationship between an event and coming out the other event, and it goes like this and can be okay sometimes, and then it spikes up. All we really, I guess, would be curious about is the nexus between the purpose of the absence and family violence leave, and if that link is made, the employees should have access to the leave. There's no question about that.
Elizabeth, just picking up on what Kathy said, obviously for those of us who followed, both the Royal Commissions, child abuse, family violence, a range of other things, we know that historical offences have long, you could have been offended against many, many decades before and still be suffering. Have you seen that in the research with the with workers in this area?
Yeah, so about 13% of the people who participated in our study had experienced violence both as a child and then in one or more relationships as an adult. What I'm really struck by within the healthcare context is that people who have experienced violence within their family at home are then coming to a workplace where they're routinely exposed in a secondary way to stories of violence and abuse from their patients, and all healthcare professionals, if they're doing what we ask them to do, which is to ask patients about violence, would be hearing those stories. And they're also in an environment where they will, from time to time, experience aggression and hostility from patients, and they may also experience bullying or more substantive abuse from colleagues. So it's a point where a lot of workers might be experiencing cumulative trauma. And I think, as you've really well pointed out, recovery is not a linear process. And there's going to be different things that come up at different points. And your workplace and what you're experiencing in your workplace may be part of what triggers difficulty within your recovery journey. So within a healthcare context, I think we have a lot of things to hold in mind.
And it's interesting, and we'll have to finish on this, but if you consider where you started, Elizabeth, with saying that having had an experience or a personal understanding of family violence can be a great asset, it's also incumbent on the organisation to take particular care of survivors, in their work.
Right.
Yeah. We'll have to leave it at that, but can you please join me in thanking our panel, Georgia, Stuart and Elizabeth. Thank you. Thank you very much.